Greetings, dear learners. In the last class, we were learning the toxidromic approach to the management of poisoning. Under that, we finished the learning various toxidromes like anticholinergic toxidromes, cholinergic toxidromes, symptomimetic toxidromes, opioid toxidromes, then sedative hypnotic toxidromes, and serotonin syndrome, as well as neuroleptic malignant syndrome. Then we covered the remaining guidelines on the management of poisoning, that is the adequate follow-up along with the nursing and psychiatric care. Before moving ahead, few important things regarding management and diagnosis that we need to know must be covered under the management part, that we shall know the precautions related to the management of poisoning in cases of the pregnancy, and the diagnosis of poisoning in cases of death that were left along with the diagnosis part. So, the special precautions in poisoned pregnant patients shall be taken. In general, a successful outcome for both mother and fetus is dependent on the optimum management of the mother, and the proven effective treatment for the seriously poisoned mother should never be withheld based on the concern regarding the fetus, because there are the many situations that depends that the placental transfer of the drug and the placental transfer of the antidotes that will decide the fate of the fetus. So mother's health should be given the priority as compared to the fetus health when the concern of the such situation arises. Certain important issues that makes the pregnant woman to be handled separately are the physiological issues that already we very well know that pregnancy is a totally different physiological condition, where a pregnant woman's total blood volume and cardiac output are raised through the second trimester and into the later stages of the third trimester. This means that the signs of hypoperfusion and hypotension will manifest later than they would be in a woman who is not pregnant. And when they do, the uterine blood flow may already be compromised. For these reasons, the possibility of hypotension in pregnant women must be more aggressively sought, and if found more rapidly, it shall be treated. Maintaining the patient in the left lateral decubitus position will help to prevent the supine hypotension resulting from impairment of systemic venous return by compression of the inferior vena cava. The left lateral decubitus position is also preferred position for the gastric lavage if it is necessary. So the pregnant woman shall be preferably be told to lie on the left lateral decubitus position. Because the tidal volume is also increased in the pregnancy, the baseline PCO2 will normally be lower by approximately 10 mm of Hg. Appropriate adjustment for this effect should be made when interpreting the arterial blood gas analysis. So, the arterial blood gas analysis interpretation in the pregnant woman will also change due to this physiological effect. Another important issue is the antidotal issues, that in general antidotes should not be used if the indications for the use are equivocal because of the risk of the antidotes on the fetus and its side effect. On the other hand, antidotes should not be withheld if their use may reduce the potential morbidity and mortality in the pregnant woman. Risk and benefits of either decision must be considered case-to-case basis. For example, reversal of the opioid-induced respiratory depression calls for the use of naloxone. But in an opioid-dependent woman, naloxone can precipitate acute withdrawal syndrome, including uterine contractions and possible induction of labor. So, very slow, careful intravenous titration starting with the 0.05 mg naloxone may be indicated unless apnea is present. Cessation of breathing appears imminent, or the partial pressure of oxygen or oxygen saturation is already grossly inadequate. In these instances, naloxone may be administered in the higher doses, that is in the range of 0.2 to 2 milligram, or assisted ventilation may be provided, or a combination of assisted ventilation and a small dosage of naloxone may be given to such patients. Another scenario could be a paracetamol overdose, in which it is a serious maternal problem when it occurs throughout the pregnancy, but the fetus is at greatest risk in the third trimester of the paracetamol overdose. Although paracetamol crosses the placenta easily, N-acetylcysteine, that is antidote to the paracetamol, has somewhat diminished transplacental passage. During the third trimester, when both the mother and the fetus may be at the substantial risk from the significant paracetamol overdose, immediate delivery of a mature or a viable fetus may need to be considered. So this is the different approach to the management of the paracetamol poisoning in case of the pregnancy. In contrast to the situation with the paracetamol, the fetal risk from the iron poisoning is less than the maternal risk. So the iron poisoning is the another situation where it should be handled differently, because desferoxamine is a largely charged molecule with a little transplacental transport. So it should never be withheld without of unwarranted concern for the fetal toxicity when indicated to treat the mother, as it will not cross the placental barrier, so it can be given for the mother for the treatment. So knowing the nature of the poison, their antidotes, their effect on the pregnancy, transplantation, placental barrier and others effect is helpful in deciding the proper management in the pregnant women. Similarly, carbon monoxide poisoning is particularly threatening to the fetal survival. The normal partial pressure of the oxygen of the fetal blood is approximately 15 to 20 mm of Hg. Oxygen delivery to the fetal tissue is impaired by the presence of the carboxyhemoglobin, which shifts the oxyhemoglobin dissociation curve to the left, potentially compromising an already fragile balance. For this reason, hyperbaric oxygen is recommended for the much lower carboxyhemoglobin concentration in pregnant women compared to non-pregnant women, as it is the carboxyhemoglobin is a substantial risk for the fetus. So with this, we can understand that the pregnancy poses a challenge in the management of poisoning. So we need to know the exact nature of the poison and manage the patient accordingly. With this, we finish the management of poisoning. One small topic that is very important left before moving to the analytical toxicology is the diagnosis of the poisoning in the dead. So coming to the diagnosis of the poisoning in the dead. One of the important cause for the unnatural death is the poisoning. So in all cases of the poisoning, postmortem examination is recommended. With the help of postmortem examination, we may help the investigating agencies in confirmation of the death by poisoning, finding exact reason for the cause of death, and preserving the relevant sample for the toxical analysis and collection of other circumstantial evidences to support the investigating agencies apart from the routine benefits of the postmortem examination. So it is important to diagnose poisoning in the dead patients. For this, following a step of examination shall be followed, that is, the clinical history shall be taken detailed and elaborately. Then the postmortem examination, from the external examination to the internal examination and examination of all the systems, and then the preservation of the samples for the toxicoanalysis, that is laboratory analysis of the viscera. Then the same samples may be tested over the animals for the diagnosis, and then the moral and the other circumstantial evidences may all help to diagnose the poisoning in dead patients. So coming to each of them one by one. A full clinical history should be taken from the relatives, people present with the victim at the time of incidence, and investigating officers. Prepare a record of the drugs, medications to which the deceased had access. Visit to the crime scene if possible and get the important clues in the form of empty bottles, vials of the drug, injectable syringe and others. These all will help to develop a plan or understand the situation of the patient before the death. Then on the examination, postmortem examination, routine postmortem examination as we do perform shall be done. A specific thing that we must be concerned in case of poisoning that we will be talking. So the examination of cloths is an important aspect in that of the external examination. In that, cloths, corners of the mouth or other surface of the body may show the poisonous stain, mark of the vomit or the feces. So they all shall be collected and preserved for the toxicological analysis. And even the bedside test on them may be performed for the spot diagnosis of the poison. Then look for the stains on the clothes and any other body parts and collect the sample from there. Then the color of the postmortem staining and the external examination shall be noted. Then examine for the natural orifices. Then examine the skin, all the injuries, and apart from the injection marks or any other changes shall be looked upon in the external examination. Then the routine postmortem changes shall be observed like rigor mortis, like hypostasis and any other decomposition changes. Color of the hypostasis is the characteristic of different poisoning. Here is the list of the different colors of the postmortem stasis in case of different types of poisoning. Like the hypostasis of black color is seen in case of opioids poisoning or in case of mummified bodies as well. Bluish green hypostasis is seen in the hydrogen sulfide poisoning. Bluish violet color is seen in the asphyxial deaths. Bright pink color is seen in the hypothermia, refrigerated bodies taken out from the cold water. Bright red color hypostasis is seen in the hydrocyanic acid, burns, refrigerated bodies. Then the bronze or grayish brown hypostasis is seen in the septic abortion caused by the Clostridium perfringens. Then cherry red color of discoloration on the hypostasis is seen in the carbon monoxide poisoning. Chocolate color hypostasis, chocolate brown color hypostasis is seen in the acetinylide, aniline dyes, bromates, chlorates, potassium chloride, nitrites, nitrobenzene compounds, potassium bicarbonate. And the dark brown or yellow color hypostasis is seen in case of the phosphorus poisoning. So with the help of the color of the postmortem staining, we may know the type of poison that has been consumed by the victim before the death. And accordingly, we may suspect that this particular poison is there and we may find other signs as well on the body. Then after the examination of clothes, looking for the stains and the color of the postmortem examination, then we should look at the natural orifices. Natural orifices like mouth, nostrils, rectum and vagina may show the presence of poisonous materials or the signs of it having been used. So they should be examined properly. From there, some remnant of the poison or the other evidence may be seen on the natural orifices. Then examine the skin properly. A skin should be examined for the alopecia in case of metallic poisons, bullaes, injection marks, jaundice, hyperkeratosis and the hyperpigmentations. Then the injuries apart from the body skin changes, injuries on the body shall be looked upon. The normal traumatic injuries on the body, abrasions, bruises, wounds may suggest the violence in addition to the poisoning. They should be properly examined, identified and noted in the postmortem report. Then after the external examination, we shall move to the internal examination. Under that, we must specifically look for the smell, any peculiar smell, Mouth, throat and associated structure in case of ingested poisons, because most of the poisons are taken in through the oral routes. So the gastrointestinal system shall be examined properly. That includes esophagus, stomach, duodenum, intestine, then liver, respiratory tract for the inhalational poisons, kidneys that help in the metabolism or excretion of the poisons, then heart and the genitourinary systems shall be examined properly in case of the poisoning. Usually the smell is obvious even before opening the body. If a smell is not obvious, a skull should be opened first to note the smell in case of at the time of autopsy. If other cavities are opened first, a smell may be masked. In some cases, opening the body merely makes the smell more obvious. So, you can know from this table that different types of smell are seen in the different types of poisoning. So, with the help of a smell alone, we can suspect a particular type of poison. Acrid odor is seen in of the chlorohydrate or paraldehyde poisoning. Bitter almond smell is seen in the cyanide poisoning. Burnt rope smell is observed in the cannabis or marijuana poisoning. Carrots smell is seen in the water hemlock or the cytotoxin. Then the disinfectant or hospital odor is seen in the carbolic acid poisoning or creosote. Garlic odor is seen in the arsenic, arsine gas, dimethyl sulfoxide, organophosphates, phosphorus, selenium and tellurium compounds. Glue smell is observed in the toluene and the other solvents. Kerosene-like odor is seen in the organophosphate compounds. Both garlic and the kerosene smells have been described in case of the organophosphate compounds. Mothball smell is seen in the camphor, naphthalene, para-dichlorobenzene. Then peanuts smell is seen in the nitrophenyl urea, WAC or rat poison. Then pears smell is seen in the chlorohydrate and paraldehyde. The same pears and acrid smell are seen in the chlorohydrate and paraldehyde. Rotten egg smell is seen in the carbon disulfide, dimercaptosuccinic acid, DMSA, disulfuram, H2S, mercaptans, N-acetylcysteine. Rotten fish smell is observed in the ammonium phosphide poisoning and zinc phosphide poisoning. Sweet, fruity or apple-like odor is a smell in case of acetone, chloroform, ethanol, isopropanol, lacquer, nail polish remover, nitrites. Soup polish smell is observed in the nitrobenzene poisoning. Then stale tobacco is a smell in nicotine poisoning. Vinegar is a smell in acetic acid poisoning, and wintergreen is a smell in methyl salicylate poisoning. So, with the help of the smell, we may know different types of the poisonous substances. So, an autopsy surgeons or the physicians nose shall be very smart to smell different types of the toxins. So, basically the autopsy or the forensic investigation is the laws of deduction, where you deduce by ruling out what it is not possible, so it is also not possible. So there are multiple differential diagnoses. By ruling out each one, you deduce to a conclusion that this is the best possibility of this particular situation. So in a similar way, for the diagnosing exact poison on the clinical examination is basically the art of the deduction. And once the appropriate toxins has been decided, so accordingly we will manage the patient. But the confirmatory test will be done through the blood examination. Finding the quantity of that substance in the blood is the confirmatory test for the poison. Then further, after the looking for the smell, examination of the gastrointestinal tract, including from the mouth, shall be done properly. Mouth, throat and tongue shall be examined for any evidence of the inflammation. erosion, ulceration or staining. Cause of the oral ulcerations are the cantharidin, corrosive poisoning, iodine, mercury chloride, paraquat or the diquat poisoning. The same ulcers are produced in the case of the esophagus as well as the stomach due to these above ulcerating agents that cause ulceration in the mouth, that is cantharidin, corrosives, iodine, mercury chloride, paraquat and the diquat. So we must know what are the poisons that produce oral ulcers. Then pharynx will show the corrosion and ulceration, and the causes will be the same as the oral ulcers. Areas of the necrosis is seen in the drug causing agranulocytosis like amidopyridine, barbiturates, dinitrophenol, sulfonamides and thiouracils. Esophagus shows softening and de-esquamation of the mucosa, mainly produced by the alkalis. Acids usually produce more destruction in the stomach, whereas the alkalis produce more de-esquamation and destruction in the esophageal mucosa. Cause of the ulceration on the esophagus and the stomach is the same as that of the mouth ulcers. Then perforation in the esophagus may be found in several corrosive ingestion, swallowed foreign bodies like the button batteries and the coins. Stomach examination should be done meticulously as it will help to find many information related to the poisoning.